This is Urban Health Today, and I'm speaking with Alina Czekai, Vice President of Strategic Partnerships at Cohere Health. She's here to talk about a new CMS initiative that will improve patient access to care while decreasing provider and payer burden through enhanced prior authorization. Thanks for speaking with me today, Alina.
Thanks so much for having me, Tamara. Great to be here.
So let's get started. Please talk about your background with CMS and your work with Cohere Health.
Sure. So my background is in health policy. I studied health policy in undergrad. I was like many other college students who initially went into school thinking they were pre-med. And I realized I didn't want to spend 4 years taking biochemistry and chemistry classes that just didn't really hold my interest. I knew from a young age that my passion was for healthcare. And so that's kind of how I found my way to public health. So studied public health in undergrad, and then went on to get my master's in health policy, public health at the George Washington University. So throughout my career, I've kind of seen myself as a connector in the industry. I enjoy working with stakeholders across the delivery system, whether it's patient advocacy groups, that's where I started my career, to health systems, insurers, innovators. And so had a start of my career in the nonprofit space, in the startup space, and then went to work for CMS in I think it was 2019 or so, and started at CMS as working at the Innovation Center. So the CMMI Innovation Center works on developing models to basically test new value-based payment methodologies in the Medicare program. And so at CMMI, I was working on the rural model portfolio, so developing payment models and programs that could be implemented in rural communities. Really enjoyed my time at the Innovation Center, but then had the opportunity to move over to work for Administrator Verma. And so my role working with the administrator was effectively to be kind of her liaison with the healthcare industry. So kind of tapping into my pure love of working with stakeholders across the delivery system. And so when there was a proposed rule or an issue that the agency was looking at, I was the voice of the agency in working with these different groups, getting their stakeholder feedback, getting their view from their unique perspective in the delivery system, and ultimately ensuring that their perspectives were incorporated in policy design. And so had the opportunity to work with the administrator and her team on what was her initiative at the time, improving patient access to care, the Patients Over Paperwork initiative that was really focused on reducing physician burnout, reducing barriers to patient access to care, and hosted a number of listening sessions and different forums where we heard, front hand from patients who were at the challenge of prior authorization and weren't able to get their medications on time because of the arduous process of prior authorization, or patients who had to almost ration their medications because they weren't sure when they'd be hearing back from their insurance company about their prior auth requests being approved. Heard from physicians who they had employed staff who would be working on submitting prior authorizations day in and day out. So just kind of the challenges with this process from each different stakeholder group. And so when I left the agency in 2021, gosh, time is flying, but I knew that I wanted to go to an organization, that was a high growth company. I missed the startup energy. And so I knew I wanted to go to a company that was really focused on changing the underlying infrastructure of our delivery system. So there's so many impressive, cool digital health companies out there. But what I loved about Cohere is that it's really focused on starting with prior authorization. So a process that no matter what kind of patient you are, no matter what specialty care or primary care you're using, chances are your care needs to go through a prior authorization request. And it's a process that each stakeholder group, right, health plans, patients, and physicians can agree needs to be improved. And so I immediately was hooked by Cohere being focused on this problem. But then, of course, when I got to meet the leadership team, the really smart folks working at the organization, I decided this is my next adventure. So I've been with Cohere for a bit over 2 years now. I've seen tremendous growth, throughout the organization. I think when I started, I was maybe the 120th employee, but now we're over 600 employees. We're Boston based, but we have a remote, very diverse workforce. Some of the smartest folks that I've come across in the delivery system. And we're all mobilized by our mission to really improve access to care for patients, reducing physician burden, reducing physician burnout, and ultimately enabling health plans to do what they do best, right? Taking out some of the complex and arduous functions that they had been managing, helping them to improve their efficiency, helping them to improve their workflows. We all know that healthcare is a really complicated process when it comes to revenue cycle management and how healthcare is really paid for. But we think if we're able to help streamline this process, we can have a better focus on quality. We can have a better focus on reducing unnecessary cost, unnecessary fraud, waste, and abuse. And so that is our focus. That's what we work on day in and day out. And that's why I'm really proud to be a part of the Cohere team. My role in particular as Vice President of Strategic Partnerships. So I'm responsible for thinking through, what are organizations outside of our traditional customer base, which is health plans, that we can partner with. So it might be other digital health innovators that we develop collaborative strategic partnerships with. It might be at-risk primary care groups or value-based specialty care groups who have a different model, right, for caring for their patient population, but also are impacted by prior authorization. So that kind of goes back again to my just love of working with innovators and individuals and organizations across the delivery system, and really being able to find kind of creative collaborations. And so just absolutely love my role and excited to share more about what we're doing.
Can you talk about CMS, the Centers for Medicare and Medicaid Services, for Medicare Advantage, State Medicaid, and CHIP? What is the problem they're trying to address with this new initiative?
Sure. So the Centers for Medicare and Medicaid Services, so CMS, in government, we love our acronyms, but CMS is an agency under the U.S. Department of Health and Human Services that is primarily focused on the Medicare program, Medicaid, Medicare Advantage, other managed programs. And they have a responsibility to basically protect taxpayer funds as it's used, in support of these programs. And so CMS is constantly thinking through ways, how can we save taxpayer funds, right? But more importantly, how can we ensure that the care that is being delivered to these patient populations is high quality, is safe, right? Is protecting patient privacy, patient rights, is not putting unnecessary burden on the physician community, the nursing community, nursing homes. And so CMS, from my time at the agency, was very focused on improving prior authorization. And they had a proposed rule, which ultimately was pushed out right at the end of the Trump administration. It was kind of hastily moved through the rulemaking process. There were concerns, about that haste. And so ultimately it was withdrawn. And then a new proposed rule was released. this past fall, which Cohere was pleased to submit comments to the agency on. But what you see there is prior authorization, interoperability. These issues are issues that both sides of the aisle can agree on, right? It was during the Trump administration that something was proposed, and then during the Biden administration that the torch has kind of been carried. In any administration, you'll have your political leadership. So the head of HHS and other leaders there are political appointees by the president. Same with CMS under HHS. A number of the leaders are political appointees. But the majority of people in the agencies and in the departments are civil servants. So they are non-political individuals. They are there regardless of who's in office, a Republican or a Democrat. And they're the subject matter experts developing these proposed rules most of the time. They're the ones carrying the torch from agency to agency. And so the people really who were writing the proposed rule in the Trump administration, it's a lot of the same people. And so what's terrific about that is, they're able to take in feedback that they get, that they got during the Trump administration, and they were able to incorporate that in the new proposed rule under the Biden administration. And so what we're seeing now across the delivery system is much more, I would say, stakeholder support for this proposed rule. The health plan community in particular had concerns about mostly the implementation period of time that was proposed in the Trump rule. But now what we're seeing is a lot of their concerns have been remedied in this new proposed rule. So currently, the agency is reviewing comments that were submitted during the proposed rulemaking process. They'll be reviewing each and every comment. They really do read all of them. They'll be addressing them where necessary and incorporating that feedback into the final rule, which we can expect to be released later this year. And I'm happy to share a bit about the specifics in that proposed rule if helpful.
Yes, please.
Sure. So like I said, prior authorization is a process that has been around for a long, long time. It's one of many levers that health plans use to be able to improve the revenue cycle management process. It's a lever that health plans use to reduce unnecessary utilization, unnecessary spend. And ultimately, this proposed rule is requiring the use of electronic prior authorization by health plans and the physicians in their network. And so what that really means is the agency is encouraging the delivery system to move away from the old fax machine process, move away from the very transaction-minded process, and move toward a process that is technology enabled, move toward a process that is supported by interoperability, and one that makes the prior authorization process dynamic. And that's something that we at Cohere are focused on day in and day out. So, we're very proud that we're already meeting, if not exceeding, a lot of the requirements that CMS is outlining in the proposed rule. Our core solution is intelligent digital prior authorization. We have, enabled a solution that supports automatic decisioning, that significantly reduces the amount of time that a physician and their staff spend on administrative processes like prior authorization. And we're also able to have a technology that is matching up the prior authorization process with the best in evidence-based medicine. So we partner with organizations like the American Academy of Orthopedic Surgeons, the American College of Cardiology, to ensure that the standards and the clinical guidelines that we have in our technology meet the evidence base. And so that in turn allows for care that is very high quality, that is making prior authorization decisions on evidence-based medicine. And so again, is the key part of this proposed rule is moving the system toward digital prior authorization. You know, we like to think that we've been in this space a little bit, and so we were happy to offer some of our perspective to the agency and to offer some of our thoughts. So one of the big provisions in this proposed rule was the prior authorization requirements, documentation, and decision API. So under this new proposed rule, payers would need to build and maintain a fast healthcare interoperability resources, also known as FHIR, application programming interface. So an API that effectively automates the process, again, for providers to determine prior auth requirements, documentation, and decision guidelines. And so by having these APIs, the goal here is to really reduce providers' prior authorization burnout, ensure patients, providers, and health plans can all access the appropriate information to make informed, efficient care decisions.
So just to
And
be clear, are we talking about, I'm sorry to interrupt, but are we
Sure.
talking about CMS right now, or are we talking about Cohere? Because I know Cohere has some proposals of their own. Are we talking about CMS right now?
Yeah, so talking
sorry.
about what's in the CMS
Got it.
proposed rule, and then kind of how Cohere thinks about it.
Got it.
And so, you know, with this provision of the rule, we're super supportive of it. We think the agency is, you know, taking a great step toward automating prior authorization. You know, again, our solution is already doing that today. So we're digitizing the authorization process across different channels, whether it's fax, web portals, EHRs, to really unify previous siloed healthcare data. And then another key provision of the proposed rule is in regards to denial reasons. So sometimes if a patient under kind of traditional utilization management, a patient might go in for care and their physician and the staff, you know, will submit an authorization request, and it might be denied for a reason that never gets back to the patient, which is really frustrating and can certainly, you know, result in a patient abandoning their care altogether. If I go into the physician's office and they say your health plan's not going to pay for this, that's a really frustrating process and something that, you know, we believe patients and their physicians should have full transparency into understanding, you know, what is covered under their policy, and if care is in fact denied, why, and what could be a better route for that patient. So under the CMS proposed rule, payers will now need to include a specific reason when a prior authorization request is denied. And again, the whole purpose of this is to really facilitate better communication and understanding between the payer and the provider, and if necessary, you know, result in a new submission of an authorization request. And you know, Cohere's of course very supportive of this measure that the agency is taking. We think this level of transparency is super important. Patients should feel empowered in their care decisions. They should know, you know, what's going on. And today our platform is already doing this. So if care is denied or if it's pended, you know, we give very specific reasons for denials. So a physician, you know, can determine the best next step so a patient feels involved in their care. And we're also publishing, we publish our decision and care path guidelines for users. So, you know, you can't have an interoperable healthcare system without pure transparency. And so we think this step is one in the right direction. And then another key provision that the agency outlined in this proposed rule is prior authorization timeframes. And so the effort here from the agency is to basically ensure that patients have a decision about their care in a much faster period of time. And so right now, the agency is proposing that a payer needs to send their prior authorization decision within 72 hours for an expedited or urgent case, and within 7 calendar days for standard, non-urgent requests. And so today, health plans oftentimes have different, different turnaround times for decisioning. And so the effort here is to really streamline that. And if you think about it from a health equity standpoint, it's ensuring that no matter who you are, where you live, who your health plan is, your care will be at the same standard of turnaround time for someone across the country or someone with a different health insurance plan. And so we think this is a step in the right direction, but 7 days or 72 hours for an expedited urgent case, that's still a lot of time. And so we think that instead of focusing on hours or days, we think the focus should be on automation. Our core solution is focused on delivering automatic decisions when appropriate. And we think that at least 60 to 70% of authorization requests should be instantaneously adjudicated. And again, that's empowered by technology, empowered by tools like what Cohere offers, because that allows the patient to proceed to that next step in their care journey. If you have, a very serious medical event and you need attention, hours are really important. The American Medical Association, they've done a number of surveys with physicians, and they've reported that 93% of physicians have reported care delays associated with prior authorizations. So there's care delays, there's patients potentially abandoning treatment, there's adverse medical events. And so now we have a really critical opportunity to shape policy that better sets up patients and their providers for success. And so we think, new and improved turnaround time requirements can serve as a driver for really decreasing provider burden, ensuring patients have better access to care. And again, forward-thinking payers, they're already investing in intelligent technology that provides automatic decisioning that really streamlines the prior authorization process. And so we would just encourage, again, the agency to be focused more on the automation piece than the, days, hours, because if we take that approach, we're going to be left in the same old transactional system that we've been in. But still, improved turnaround times is a step in the right direction. And then CMS also talked about gold carding programs. And so gold carding is effectively, giving providers waived prior authorization. And so we think that while that's well-intended, gold carding programs can potentially increase authorization complexity, effectively hindering one of the payer's important tools for impacting value and quality. And so we recognize at Cohere that the key role of providers, in interoperability is so important. And we're concerned that manual processes will still persist if the use of new technology isn't incentivized more. So instead of gold carding, we believe green lighting is a better way to incentivize providers and really rewarding high-performing physicians. So with the approach of green lighting, it really affords them reduced administrative burden, even faster authorizations where clinically appropriate, kind of like a fast track, no red lights. And so we think that once providers implement these new capabilities into their workflows, providers consistently use electronic prior authorization systems. And then finally, another and final key provision of the proposed rule is around prior authorization metrics. So under the proposed rule, impacted payers will need to publicly report certain prior authorization metrics by posting them directly on their website, or publicly accessible hyperlinks. And we're very supportive of this policy. Again, we are supportive of the push for greater transparency in the care delivery system. Transparency, again, is super important for interoperability, progressing toward value-based care, and ultimately having prior authorization processes that meet the needs of patients, providers, and health plans. Today we're already supporting this type of transparency between health plans and their network. We deliver things like scorecards on a quarterly basis to our health plan partners. And we think this is a really important step to ensuring that providers and their health plans have understand how they can continually improve and deliver better care. There are some vendors out there that are a bit concerned about other vendors embedding their content. So we just, encourage the agency to keep an open mind when reviewing feedback and comments on the proposed rule, to ensure there is that proliferation of transparency in the system, to ensure there's not information blocking, to ensure there's not kind of monopolistic approaches, because all stakeholders need to be on the same page. There needs to be transparency as we move forward under this new rule.
So walk me through an example of how this should work. Pick a claim, and then walk me through what this looks like now, or what it look like.
Absolutely. So let's use a knee surgery as an example. So let's say Mrs. Jones goes into her physician's office. She's been having knee pain for quite some time, and her physician then submits an authorization for knee surgery. I'm not a physician. I have a background in public health. So we're just going to use very basic terms for the viewers, or for the listeners, excuse me. And so let's say Mrs. Jones, her authorization for knee surgery has been submitted, but she's never done conservative care. So she's never tried physical therapy for her knee pain, or she's never received a steroid injection for her pain. So as the back office staff at the orthopedist's office is submitting this auth request, because our solution is intelligent, technology enabled, we're dynamic, right? So traditionally, a solution would review the request and then review the guidelines and say, you know what, Mrs. Jones has never received physical therapy. We're going to deny this request. But that makes the approach to healthcare very yes and no. We know not all, healthcare decisions are that binary. So in our solution, we're able to surface recommendations based on the evidence base that would get Mrs. Jones the right next step in her care, while ensuring that it's going to produce quality results. It's going to improve her medical state. And so we're able to surface options like, hey, Mrs. Jones has not completed the required physical therapy in order to have surgery. This is required by her health plan. It's recommended as best practices by the American Academy of Orthopedic Surgeons. If you proceed with requesting this surgery authorization, it's going to be pended for review, and then it will go to a peer-to-peer. Or if you'd like to have an automatic decision and know today what's next in her care journey, we recommend you switch this request to a physical therapy request, right? Our whole approach is to getting the patient to a yes, right? Getting the patient to know what's next in his or her care journey, while avoiding those painful, frustrating, annoying denials. So then Mrs. Jones will then be able to get scheduled for physical therapy. She'll proceed in that approach. Let's say, a few weeks go by, her pain hasn't subsided. she goes back to her surgeon, and her surgeon says, you know what, you tried physical therapy. I don't think that was the right next step for you. We're able to pick back up on the care path where the patient left off, right? And help the physician's office determine what's the next best plan of treatment. Is it going in for imaging to determine if there's something else going on? Is it getting the patient worked up for surgery? And we're able to ensure, again, that this whole process is taking into consideration not only what the health plan requires and what the health plan will pay for, but what's the best, for evidence-based medicine. And then, you asked, how should this process work? So that is kind of from a clinical standpoint, from a patient journey standpoint. But if you think about, what's happening from the health plan standpoint, they're able to save, administrative dollars just by working with an intelligent prior authorization solution. But then they're also enjoying incremental medical expense savings by reducing care that's not clinically appropriate, right? So it wouldn't have been appropriate for Mrs. Jones to go straight to surgery, skipping over conservative care. So by rerouting her onto a process that's more clinically appropriate, there's going to be reduced unnecessary medical spend. And so again, we see ourselves sitting almost in the triangle of the physician and their staff, the patient and the health plan, and really pulling levers that improve the process for all. So we're really proud of the fact that 92% of providers who use our solution are satisfied. We're able to deliver 4 days faster access to care for patients. And then when it comes to med expense savings, we're delivering between 25 to 40% reduction in costs associated with prior authorization. So making all, 3 of those stakeholder groups happy and, enjoying a process that is so old, so antiquated, but is finally being revitalized and supported by technology. And so the proposed rule from CMS helps innovators like Cohere, to have standards that, again, we're typically exceeding them, but it brings to the market, hey, these are the new rules of engagement when it comes to prior authorization. Physicians deserve better, health plans deserve better, patients deserve better. And so really it's up to a lot of the innovators like Cohere to help the health plans get to that point, right, where they can meet the compliance and the proposed rule requirements.
So just to circle back, just so I make sure I understand it. So the AI recommends to the physician before they go to the surgery route, for example, to say, hey, before you submit this authorization for surgery, why not try conservative care such as physical therapy or injections first and submit a claim for that, for prior authorization. Okay, and so it's a more gradual escalations then, depending on how the patient's needs. Okay, I understand. Thank you.
And yeah, you bet. And so you're absolutely right. It starts with kind of a questionnaire process that in the technology, the back office staff is, responding to, is the patient's pain radiating up and down her leg, or is it on her left side, right? Like asking different questions. But then our technology too has gotten, really sophisticated, where in addition to ingesting these questions, we're also applying AI machine learning to the clinical notes, right? So we're able to capture what it says in the actual clinical note. Our technology can read the handwriting and all of the detail in those notes, and also apply that then to the decisioning. So our approach really is to ensure that we're getting all the information we can to help the technology make the most informed decision. And then, of course, if there is a situation where, let's say, Mrs. Jones, her physician's office doesn't want to proceed with physical therapy, maybe she has bone on bone, maybe there's some clinical reason why she's, not an appropriate candidate for that, then the request will go to our physicians, our nurses on staff to really dive deeper into that case. Sometimes they might need to go back to the physician's, office and say, hey, we saw, the patient had an image done a few months ago. Could we take a look at that as clinical justification? Or, what, it's time to schedule a peer-to-peer. So we'll get one of our orthopedists on the phone connected with, that physician's office, and they'll have a collegial conversation about that patient. And there'll, be an opportunity to add more color to the case. And if, appropriate to proceed with surgery, those physicians on the phone together will make that decision. So we use various, approaches, all ensuring that, there's the right information. We're ensuring that it's the most clinically appropriate care, ensuring that we're still being, good stewards of health plan dollars or Medicare dollars, and getting the most appropriate outcome for that patient at the end of the day.
Does the patient have access to this information along the way? Is there a portal
so today we do not have a portal
Mhm.
For the patients, but we do encourage the physician and their staff to use the information that we're presented and use it as an opportunity for a conversation with their patient. I think a lot of times, we have all kinds of digital health solutions and point solutions that are available to patients, right? I don't even know how many apps I have on my phone that, are seeking to accomplish that. But what we've observed is, it can be challenging to present complex medical information to a patient without a bit more context from a physician or a nurse or a partner who can really help them understand that. So today, our approach is, again, ensuring that physicians are having those, back and forth collaborative conversations with their patients about their care. And, we also provide kind of tools and approaches to support the patients, to support the providers' conversations. That's part of why we provide our guidelines so transparently, right? That can be a tool for the provider to explain, hey, you know what? This is evidence-based medicine. This is what is accepted as clinically appropriate. You're better off trying this approach. Like, it is clinically proven to deliver the best possible outcome for you and your health. And, I'm your physician. I care about you, and I want to make sure that you're getting the best care you can get.
Now, this sounds a little bit, does this sound, it sounds to me like value-based care, a value-based care model. Is this modeled at all on a value-based care in terms of?
Yeah, absolutely. So, in order to have value-based care, again, you need to have all of the key stakeholders on the same page, right? There needs to be set rules of engagement. There needs to be an agreement that, providers will be rewarded based on quality, not necessarily utilization. So we see improving prior authorization as a really important step toward value-based care. We also partner and talk with a number of groups that are actively, managing populations under risk. We're able to help them get a better view into their population, helping them to get a better view of physician quality, right? That's a key part of value-based care, rewarding high performers.
Mhm.
So that absolutely is our focus and kind of our big picture vision. And frankly, it's why I joined the organization, because I want to be a part of an organization that's moving our delivery system from one that is volume-based, one that's transaction, to one that's, illuminating care, to one that's rewarding value, and delivering better results.
Now, speaking of AI, I read recently that insurers are starting to use AI to process claims and prior authorization. How does that affect prior authorization, if at all?
Yeah, so I think we're seeing AI across the delivery system, right? Artificial intelligence, technology, machine learning, are all really important tools that are helping the delivery system, including insurers, automate decisions, right? Whether it's claims, whether it's prior authorization. And so it's all interconnected. And what it really shows is there's an appetite, especially among health plans, to reduce unnecessary expense on administrative processes, right? There's an appetite to bring greater efficiency to the claims payment process, to revenue cycle management, to utilization management. And so I think over the next, let's say 5-10 years, we're going to see a proliferation of AI in all verticals of healthcare, but especially when it comes to automating antiquated processes, automating administrative functions.
So this is where Cohere sees the future of prior authorization in AI.
Yeah,
Correct?
so we see the future of prior authorization as something that can be and should be automated. And so we think that if we can have greater automation of functions like prior authorization, that frees up not only physicians and their staff, right, to do what they do best, caring for patients, but that also allows health plans to then start thinking about, okay, what's the next, bite of the apple? What's the next issue within our organization that we want to solve? Is it, value-based network designs with physicians? Is it, incorporating social determinants of health data into some of our programs, right? It kind of takes the focus away from these programs and processes that can be automated, that should kind of be, running along in the background. And it frees up time, space, and resources to really be laser focused on, what are the things that I can do to take, the delivery of care to the next level. So we're really excited about that because it, again, kind of highlights the focus that if we can improve these underlying kind of more infrastructure processes, we're just kind of pushing our delivery system as a whole to the next level of care, which can and should be value-based care.
Does your AI, I'm just thinking about this move for insurers whose doctors are using AI to respond to claims that I think are resulting in more denials. So how does Cohere Health's AI combat something like that?
Sure. So again, our focus is non-denial approaches to utilization management, right? So at the end of the day, our technology is using guidelines from the academies, from CMS, from the health plans, right? And then we're taking that and applying an approach that gets the patient's care to a yes, right? So a denial-based approach, again, is that kind of antiquated approach, yes or no, you can, proceed to this care or you cannot. But we like to think that we're able to help reroute to the most clinically appropriate step in their care, whether it's physical therapy, like in the example I shared before. But we know that a denial approach, that's not going to save dollars at the end of the day, right? If a patient is denied care and isn't given an alternative, they're probably just going to go find another physician who will get them a yes. So we're able to help them get to the right yes, while being on a care path that's clinically appropriate. And the numbers speak for themselves. We're able to save health plans significantly more through our approach than they would experience through those very denial-focused approaches. And what's most important is, we know at the end of the day, a denial-focused approach is not what's right for the patient. What's right for the patient is what is deemed to be clinically appropriate, whether it's a yes or a no or something different.
So would it be a fair characterization to say it's sort of an anticipation AI?
Say more about anticipation AI.
Obviously, these models were created by, using data from, as you said, the insurers, from the providers, from different places. That's how the AI has been trained. So the AI then knows, and tell me if I'm wrong. I'm just trying to work this out. So the AI kind of knows, based on the insurance or the insurer, what is going to be approved and what's not going to be approved. And so it sort of anticipates the potential response and sort of, as you said, reroutes the provider, put them on the right path to get to the approval.
Got it. Okay. Yes, that is a characterization I haven't heard before, but I think it's one that definitely matches what we do, right? So our technology is taking in thousands and thousands of auth requests. Our engineers are some of the most, brilliant people I've ever met in healthcare, and they're training the technology to do just as you say, to anticipate based on the data, based on other cases like this, what's likely to happen. If they proceed down the surgery path, what is the spend? What are the results? Is it clinically inappropriate? And how can we get the patient on the path that they really should be on that's clinically appropriate? So yes, the technology is super smart. It's probably thinking, 5 steps ahead of all of us. And it's able to, support the right thing for the patient's care.
This is amazing. Alina Czekai of Cohere Health, thank you so much for explaining this. I feel so much smarter now after listening to this.
It's not a great feeling. Well, thank you so much for having me. Always, love the opportunity to meet other, thinkers in the healthcare space and to just share a bit more about how we see the world and what we're doing to try to change it.